Hello, my name is Carol Shields from Philadelphia, United States. I have no financial disclosures. I'd like to talk to you about progress with intraarterial chemotherapy, the Philadelphia experience. It's all about kids and life and vision. As we mentioned earlier, we do still manage retinoblastoma with enucleation, intravenous chemotherapy, intraarterial chemotherapy, vitreous chemotherapy, and plaque radiotherapy. In this discussion, I will talk only about intraarterial chemotherapy. But first, let's understand the classification of retinoblastoma. We have group A, which is small retinoblastoma, 3 millimeters or less in size. Group B, bigger retinoblastoma, bigger than 3 millimeters or in the macula or with subretinal fluid. Group C has contained seeds localized within 3 millimeters of the tumor. Group D, diffuse seeds greater than 3 millimeters from the tumor. And Group E is extensive, filling over 50% of the globe with neovascularization of the iris and often opaque media from vitreous hemorrhage. So with regards to intraarterial chemotherapy and knowing the international classification of retinoblastoma, let's explore what's going on in Philadelphia. We tend to use IAC for unilateral retinoblastoma, and we tend to give it through the femoral artery and thread the catheter all the way up to the ophthalmic artery using melphalan or topotecan. Some good news, in older kids, we can actually give it into the radial artery, which is a tad bit safer than the femoral artery. Same medications, same doses in kids over the age of 5 or 6 years. Now, back in the day, we looked at intravenous and intraarterial chemotherapy when we first began. And we found intravenous chemotherapy gave good globe salvage, 90% to 100% for groups A, B, and C, less for D and less for E. And then in marches intraarterial chemotherapy, and it's giving us better globe salvage than intravenous chemotherapy, 100% for group B and C, 94% for group D, and 36% for group E. But these figures were before the use of intravitreal chemotherapy. Now with intravitreal chemotherapy, group E, we're saving greater than 50% of the eyes, up to 73% of these selected eyes. A few years ago, published in 2018 in Ocular Oncology and Pathology Journal, we looked at primary intraarterial chemotherapy, 5 years of experience, and we concluded IAC is effective as primary therapy for unilateral groups B, C, D, and E, select E eyes. And intravitreal chemotherapy is an important adjuvant to achieve comparable globe salvage rates for groups D and E eyes with active vitreous seeds. But then we took it one step further. We did a head-to-head retrospective comparison of intravenous versus intraarterial chemotherapy for unilateral retinoblastoma, published in the Asia Pacific Journal of Ophthalmology. So what did we find? Who does better? Well, we found for unilateral retinoblastoma, IAC provided significantly superior globe salvage compared to intravenous chemotherapy only for group D eyes. There was no difference for the other eyes. And here we look, A, B, C, D, E. For groups B, C, and D, giving intravenous chemotherapy, we have fairly good outcome. And with IAC, we have really good outcome, but it was no different for B and C, but it was significantly better for IAC with group D. And if we look at solid tumor subretinal seeds and vitreous seeds, for solid tumor subretinal seeds and vitreous seeds with intravenous chemotherapy, pretty good control, but with intraarterial chemotherapy, it far outshines intravenous chemotherapy and significantly better for all 3 categories. So for unilateral retinoblastoma, IAC wins. This is why we choose IAC for unilateral retinoblastoma, and this is important because most unilateral retinoblastomas group D or E, and we know that IAC is far better than IVC for group D. Let's look at a few cases here. This is a group DI, exophytic retinoblastoma, subretinal fluid nasally. The tumors involving the macula and the macula lutea is visualized centrally. We give IAC, the tumor shrinks down with only 2 doses of melphalan, and the retina is completely flat. That was a slam dunk good response. Another eye, more endophytic retinoblastoma, located mostly nasally. And by ultrasound, we saw that the temporal retina looked flat. Here's what the RetCam image showed. We couldn't see a thing. We could only see peripheral normal retina. After we gave IAC and intravitreal chemotherapy, voila, we have a macula, we have an optic nerve, and the tumor is regressed nasally, and by OCT, a nearly normal foveal contour with visual acuity of 20/40. That's pretty impressive results. Dr. Ferouz, along with our team and others, published in the Indian Journal of Ophthalmology recently, Intraarterial Chemotherapy for Retinoblastoma, a Paradigm Change. And this really has affected many centers around the world. We use the technique where we catheterize up through the internal carotid into the ophthalmic artery, but stop short of entering the artery and just allow the flow of blood to take the chemotherapy into the artery. We use IAC as primary IAC, secondary IAC, bridge IAC, and rescue IAC. We don't use tandem IAC. We don't treat both eyes at the same time, but we do something slightly different. We do staggered IAC. Right eye gets it, and then the left eye gets it 20 days later. We stagger it so we're not catheterizing both carotids at the same time. And a few special considerations with IAC. Minimal exposure. By happenstance, we were lucky to see a few patients that had small tumors that we got by with just 2 doses of medium dose melphalan. On the top, A, B, and C, 2 doses, D, E, and F, 2 doses, and that's all they needed. And they've been stable. How about the youngest and the oldest that we've treated? We tend to treat children who are 3 months of age or older, but we did treat a few under 3 months of age, those who were big and robust young children. Here's an example of a 2-month-old who had unilateral retinoblastoma. We gave IAC 2 doses, 5 milligrams. The tumor shrunk down beautifully. And we saw this child back a few months ago, and he's 8, 9 years old and looking great. We've treated a 32-year-old man from Texas. He had previous treatment for retinoblastoma, came to see us at age 32 years, had recurrent tumor. We gave IAC, shrunk the tumor down. And here's a 13-year-old girl, an older girl, who had vitreous seeds from retinoblastoma seen clinically and on ultrasound. But in her case, because she was older, we did the transradial access. So she got it through her radial artery, and it saves her risks of retroperitoneal hemorrhage, which the interventional people worry about. So finally, what is our publication on IAC? Well, we've had 14 years experience with IAC for retinoblastoma, and we published in the JAA POS 2021 our experience with 1292 infusions and a comparison based on age, race, and sex. For example, this 3-year-old boy from Mid-State, Ohio, with advanced group E retinoblastoma, beautiful regression, and an intact macula. So if we divide up the treated eyes into groups B, C, D, and E, looking at primary IAC, and let's just pick 5 years follow-up using Kaplan-Meier analysis. Group B has 100% tumor control. Group C, 80%. D, almost 80%. E, 55% control at 5 years. And this is lasting to 10 years. And this is in primary IAC for retinoblastoma. Overall 5-year globe salvage was 76%. So I tell the families, there's a 3/4 chance that we're going to be able to save your baby's eye. Median is 3 infusions and complications are very low. 1% per infusion. Now, if we compared by age, there was really no difference in control of solid tumor. The p-value was borderline, and control of subretinal seeds, no difference by age being less than 1 year versus greater than 1 year of age. No difference in vitreous seed control, but there was a difference in globe salvage. Younger children had significantly better globe salvage than older children over 1 year of age. So what about complications? Well, this was published in JAAPOS, our complications. If you look at complications, retinal ischemia, choroidal ischemia, NVD, E, I, or G, stroke or limb ischemia, based on stage of retinoblastoma, we really didn't have any significant differences based on group A, B, C, D, or E. In fact, our rate of complication is super low, only about 1% per infusion. So it has really lowered after our first 20 cases. And if you look at the age based on eye complications, no significant difference, whether the child's under or over age 1 year. And the race, no difference if they're white or non-white. And the sex, no difference if they're male or female. So in conclusion, based on 1292 infusions, our results suggest IAC provides substantial tumor control for advanced and or recurrent retinoblastoma with high rate of globe salvage and few complications. No difference based on age, race, or sex. So in summary, IAC works for retinoblastoma. Thank you from the Philadelphia group, United States, the laser-focused retinoblastoma team in Philadelphia. Thank you.